The last speaker for this session to close us out, I'm delighted to present Dr. Andrew Brouwer, who's an assistant research scientist in epidemiology, and he is an expert in modeling methods and parameter estimation and identifiability, and has a really wonderful wide range of interests that range from cancer to infectious disease modeling. And we've been working together for a while now, most recently on a lot of COVID stuff, and so I'm really excited to hear him present some of the modeling work that's been informing policy and decision-making here in Michigan. So with that, I'll pass it over to Andrew.
Great, thank you so much, and thank you for inviting me. So today I want to give a pretty casual talk, sort of chatting about some of the things that we were doing early in the pandemic, so the first couple of months of the pandemic in 2020, and sort of use that as a springboard for thinking of some of the, this session is about lessons learned, and so I want to sort of share some of the lessons learned in terms of how we think about modeling, particularly early in the outbreak, but a sort of larger, in a larger perspective of how we support modelers and then how modelers support policy. So I really want to emphasize that this work could not happen without strong collaboration between University of Michigan and the Michigan Department of Health and Human Services. So I really want to thank Marissa, who's our host today, but also Sarah Lyon-Callow, the state epidemiologist, and her team at MDHHS, and many contributors, both here at Michigan and beyond. Dean Bowman at the beginning emphasized, I think quite well, how much uncertainty we were really facing last March when SARS-CoV-2 was really just beginning to spread in Michigan. Lots of uncertainty in terms of the natural history of the virus, how many cases are asymptomatic, what's the incubation period, what's the real probability of severe disease or death. And at the same time, there was a lot of uncertainty about how the reporting rate, how much underreporting there was, how testing capacity was really changing really day by day since early on in the outbreak. On the right, if we look at our cumulative cases, we have this very hockey stick shape so around sort of March 18th, 19th. And so that we don't necessarily believe that that's the sort of the true shape of the pandemic, but really how case reporting and our testing capacity was really changing dramatically. And so trying to think about how prediction in the face of changing testing capacity was really challenging. And so just to say a couple of words about how we got into this, is that I had previously worked with Department of Health and Human Services on a retrospective analysis of modeling the hepatitis A outbreak. So prior to COVID, so much of 2018, if you think back in Michigan, there was a lot of concern about hepatitis A spreading. And that's sort of all been wiped out with COVID-19. But MDHHS reached out to us based on that previous collaboration. And I knew that Marissa and with some other colleagues had already begun. And so that connection sort of brought us together. And so I think one of the lessons that I want to emphasize is that having these connections is really important. I think that, many of us in this session have, felt how, important it's been for us to be involved. But I think we also need to recognize the sort of really unprecedented demands that the pandemic has placed on us as modelers. So, and I think one of the things Brouwer said was that we typically think about infectious disease modeling and mechanistic infectious disease modeling as retrospective. We see the curve that as it occurred, and then we figure out what happened, how and why it happened. And so prospective modeling is sort of notoriously difficult. But that's what we're being asked to do. There also really weren't established methods for dealing with time-varying testing capacity or social distancing. I think COVID-19 to an extent that has sort of never been seen before has had really dramatic changes in how people mitigate social distance, quarantine, compared to other modern outbreaks. And because SARS-CoV-2 is a new pathogen, we're really beginning to build testing capacity. And so how do you account for that when you look at your case data? Early data were sparse, they were uncertain, as I've already said. And I think a couple of people have said is that as academics, we're used to having a sort of like a question that we answer, but working with policymakers requires an enhanced flexibility, because the questions that they're interested in aren't necessarily the ones that we think of as academics or the ones that we want to answer. And so there's needs some flexibility. And just to recognize too that the development of these new models, but also continuously updating them to answer these new questions, is a huge commitment, both of time and capacity. And I think we need to recognize that not everyone has that, and that we need, what's the word I'm looking for here? Like, we need investment from both within within academia and the university, but from governments as well. So to just our experience was that the needs of policymakers changed pretty dramatically over time, and so the products that we tried to create also changed over time. So the things I'm going to sort of talk briefly through are some short-term forecasts on the order of weeks to understand likely short-term trends and incidents and uncertainty. And then moving into longer term scenarios, because although we don't know what's going to happen, we can explore possibilities for longer trends. And then, as policymakers begin to say, well, what was the impact of a previous policy? What should I do in the future? I think it's helpful. We thought it was helpful to think of it as counterfactuals, or what would have happened if different scenarios. And so this work has been, the work I'm mostly talking about was from last year, and those were shared with MDHHS and the governor's office at weekly data and modeling update meetings, and we're still part of that. So we developed a model of COVID-19 disease transmission, testing, hospitalization, and death. In retrospect, maybe a little bit more complicated than we needed, particularly as so many of the parameters were uncertain and unknown, when even a much simpler model probably could have fit. But at the time, we were really thinking about how trying to maximize our utilization of things like hospitalization, thinking about capacity there, thinking about who's getting tested, what the testing capacity is. I don't want to talk too much about technicalities here, but sort of broadly, our approach is a hybrid sampling and estimation approach. And so this is something that Marissa implemented in the Ebola outbreaks and then brought here to COVID. And this is to account for both the uncertainty and unidentifiability in the model parameters. So uncertainty in that we didn't know much about the natural history of the disease, and unidentifiability in the sense that multiple combinations of parameters could really reasonably explain the dynamics that we were seeing in the incidence of cases. And this is particularly true in the early phase of the outbreak, where really you're just seeing exponential growth. And so, for example, that means that you could have either a high asymptomatic fraction or a low asymptomatic fraction, and you just trade that off with transmission rate or other parameters, and you get the same curve. And so what we would do is fix most of our parameters at reasonable ranges. For those who are interested, we used Sobol sampling to cover our space. There's an example picture here on the right. But then we would estimate for each of those fixed values of the other parameters, transmission rate, combined parameter accounting for both the fraction of the population at risk and the reporting rate, and then also the relative reporting rate for deaths. And we would do this 1,000 times to get sort of uncertainty, to get a range of simulations that are all consistent with the data. And so in the earliest, we were trying to get sort of short-term forecasts. And so we know that forecasting long into the future is a bit of a fool's errand, but short-term predictions can be accurate. So here's a series of 1 week forecasts with uncertainty bounds. And so although there's sort of high uncertainty, the next week's incidence always sort of stayed within the sort of funnel shape uncertainty. And we were providing this at the county level early on, but we sort of soon ran out of both computational capacity and person capacity to continue to do this. And also sort of became less useful, particularly as the outbreak had begun to turn over. And so we started thinking not just at the county level, but at the sort of more regional level. And so I think a couple of people have referenced the Michigan Economic Recovery Council reporting regions. So these are regions such that most people are living and working within the same region. And we also realized that social distancing, sheltering in place, all of that was going to be incredibly highly time varying, and you need to be able to take that into account. So there's some social mobility data that we were looking at in terms of how does that correlate with kind of transmission rate. And so we moved to thinking about longer term scenarios to explore how incidents might occur over the summer of 2020. So given how the data looked like up through May, with a certain amount of social distancing, thinking about return from social distancing over a month, 2 months, 3 months, 4 months, and how that might look like in terms of incidents in these sort of blue, purple, pink, and orange lines. And in retrospect, looking back, the true summer 2020 incidence really was largely consistent with our scenarios, and mostly the fastest return to sort of normal mobility, with the perhaps exception of Detroit, which is a little bit slower. We were also interested in knowing what would have happened without the stay home, stay safe order. And so, you know, at the end of March, we were locked down, and the question is, that takes a lot of political will, and so how do we demonstrate that that was an effective policy? And so we ran counterfactual simulations, so the what if we had not reduced transmission. Here, we estimate a difference of about 33,000 cases prior to June 1st of last year and 4,200 deaths. You know, in retrospect, with the scale of the first wave in Michigan sort of has been dwarfed by things that have happened lately, more recently, but it was sort of really important at the time to think about how are we supporting our policymakers with good science. And so this work in some form was included in an amicus brief that went before the state Supreme Court in thinking about the legality of the orders. To give a flavor of things that we've been doing more recently, all of the work that I've been talking about so far was really focused on that first wave. But since then, a lot has happened. And so thinking about time varying transmission, we've been fitting continuous flexible lines. And we can sort of think about how that transmission rate here on the left for the Detroit region, how that corresponds to things like the stay home, stay safe order or the pause to save lives later in the year. And you can see that often the orders come a little bit after transmission already begins to slow down. And that's likely because people are already reacting to sort of dire news. And that dire news is also what's driving the policy. And so the policy also probably drives transmission farther down than it would have on its own. But it's sort of interesting from a sort of social perspective and how these sort of things come about. So the larger picture of lessons learned, I think that we need to recognize that this type of modeling work begins with an upfront investment. And so developing code, developing new approaches, and developing infrastructure, now that we have that, you can modify it for future outbreaks. And so it's really important that this sort of upfront investment happened. But then we recognize that policymakers have evolving needs. And so as modelers, we need to have both flexibility, but also sustained capacity. And for myself, who sort of feeling pandemic burnout last summer, I sort of struggled with being able to have that sustained capacity. Another lesson is that our relative short-term predictions can be subject to large uncertainty. And I think several of the other presenters have mentioned that the challenge in communicating large uncertainty, both to the public and to policymakers, when people want quick answers about what's going to happen. And most often the answer is, we really have no idea what's going to happen, because it really depends on how the general public are reacting and to what extent they're following things like masking orders and social distancing. And the final thing that I want to emphasize is that we really need strong connections between academic and government public health. Part of the reason that we were able to move into assisting MDHHS is because we had a prior connection, not nearly as strong as it is now. And I think that going forward, there's a much stronger connection between SPH and MDHHS. And I think that that's really great. And I think that it sort of also underscores the need for modeling literacy supported at a variety of levels, not only for people who are doing modeling, but also those who are consuming modeling, both in government and in the public. So I'll end there and just sort of, I want to again acknowledge Marissa, Sarah Lang-Callow, and a number of people here at Michigan and beyond. And with that, I will stop for questions.
Great. If folks have questions, please feel free to enter them into the Q&A thingy at the bottom. And I guess I can start. I'm just sort of curious, actually. So like, I've been thinking a lot about this lately, and it's come up in several of the talks today, including yours, this kind of role of public health and also modeling as like, so like policy, like your point about the fact that policy kind of comes in often after you start to see a bit of an inflection happening. You know, what's the role of public health as sort of the like alarm call or pot stir or whatever you want to kind of think of that as, you know, like how much of our impact of both model as modelers and as public health, scientists, et cetera, like how much of our impact is coming from essentially that like beacon of like, hey, rut-row, you know, versus the sort of policy informing side, do you think? I don't know.
It's an interesting question. I'm not sure that I have a really clear answer, but a couple of sort of things that brings to mind is that when we're saying that sort of we're playing that rut-row role, often it's not that we think that things are going to get bad, but it's that the uncertainty is so large that we want to try to emphasize that like things could get really bad. We don't know that they're going to, but they could. And that can be a sort of a strange place to be in when the sort of policymakers come back and they're like, but like, how likely is it that it's going to get bad? And you're like, we don't really know, but it could get bad. I also think that there's been a lot of discussion about how negative epidemiologists have been in this outbreak. And so we're always the doomsayers instead of sort of emphasizing the ways that things can be, you know, what is the good news? And sort of I'll reference Joe here, who always says like, what's the positive message that we can emphasize? And I think some of that has gotten lost maybe in our role as modelers here.
I think that's a really interesting like point, and it ties in with your comment about like communicating uncertainty. And I kind of think a little bit to like Brouwer made a comment in her talk about how journalists love the top edge of the uncertainty bound and policymakers love the bottom edge, and like, you know, how we think about different audiences and kind of
Absolutely.
their perceptions of uncertainty and things like that, which I think is very interesting.